Hello, I'm Peter Falke, Professor and Head, Department of Psychiatry, Ludwig-Maximilians University, Munich in Germany. Welcome to this program titled Clinical Scenario: Encouraging Adherence in Patients with Schizophrenia. I'm pleased to be here with Ofer Agid, psychiatrist at the Center for Addiction and Mental Health and the University of Toronto, Canada. So the things we are discussing here together are, the question is, what is the basis of maintenance treatment and what are the important points when we look at adherence in schizophrenia, and what are possible signs of recognizing non-adherence in our patients. And we'd like to start with a case to make it really vivid and lively. Emma is 21 years old and living on her own while studying at university. She had her first episode of schizophrenia, had a relapse when she was studying for her exams, and has been on oral treatment since then. She receives regular visits from the local schizophrenia nursing support at home.
Emma complains about intermittent psychosis and has stopped attending courses regularly. The visitor finds that Emma's apartment very untidy with food spoiling in the refrigerator. Pharmacy records show that she has been picking up her prescriptions on a regular basis. This does not reflect the evidence of her living condition and general appearance. What are the main points raised in this case? For example, reasons for the relapse. Could it be prevented, the relapse? The patient's age. She is very young, early in the course of the illness of schizophrenia. She's experienced symptoms despite pharmacy records of adherence. What do we really know about the level of adherence with patients taking oral antipsychotics?
So one of the key questions we might want to discuss is, why is the patient's age or disease stage of particular importance?
So there is the famous Lieberman study show this downhill trajectory. If we will zoom out and look at the first 40, 50 years of the life of a patient with schizophrenia, we will see that after the prodromal and first episode, the first episode symptoms, there is, generally speaking, deterioration. The main question is it inevitable? Can we do something about it? There is robust response to treatment among first episode patients with schizophrenia. And this is some kind of a paradox, because on one hand, we can see, and this is the clinical wisdom, downhill trajectory, and on the other hand, response, a robust response to treatment. And the question is schizophrenia a neuroprogressive illness, neurodeteriorative illness? And it's not clear, but I would say that the jury is still out, but schizophrenia might not be, at least for a subset of patients, a neuroprogressive illness. We can see that patients don't have the classic neuroprogressive, neurodeteriorating patterns in terms of their cognition, in terms of their functioning, and so on and so forth, after the onset of symptoms. So the question is, and this is in a way the paradox, because on one hand, there is some kind of downhill trajectory, on the other hand, robust response to treatment, and probably hypothetically for most of the patients, we are not talking about a neurodeteriorating course, at least what we see in the brain. And the question is, can we impact the long-term trajectory of illness? The jury is still out, we don't know, but what we know is, for example, that most of the patients that will continue to take medications and will be treated with an effective treatment and dose, will rarely relapse. And most of the patients that will stop taking their medications will relapse. And the question is, can we position our medications a little bit different according to an algorithm-based treatment to reduce the chances of relapse for our patients with schizophrenia?
But referring to the last details you have outlined, I think that's a very important point. You said, it seemed to be that if you look at data, for instance, from patients with first episode psychosis, so if they continue to take medication, their relapse rate is very low, like a few percent. But if they discontinue, within a year, they sort of relapse rate is quite high. So that's one of the facts we have to deal with in schizophrenia. Would you agree on that?
Yeah, definitely. So we can definitely prevent relapse, or I would say reduce the chance to relapse, if the patient is taking medications continuously, and maybe hypothetically we can impact the long-term course of the illness with preventing relapse.
I think that's an important point one wants to sort of position. The other thing is what you started to outline was defining possible subgroups, saying, well, it's several disorders within or under the umbrella of schizophrenia. And I think that from the literature, from the long-term literature, it seems to be clear that there is a subtype where they are quite fine, so they might have one or two relapses, but otherwise have a good outcome. You might have a middle group of patients who have relapses but need neuroleptics for a longer time, and then certainly we have a substantial proportion of patients who have very likely relapses without having a continuous treatment with antipsychotics. So would you agree on that view? And then the question is, what can we actually do from knowing that and actually transferring this knowledge into Emma's case?
I think you're absolutely right that schizophrenia is not one illness, probably, and there are different subtypes of illness in terms of the course of illness, in terms of response to antipsychotics. One of the problems is that it's very difficult to tease apart, to identify these subtypes of patients right now. I guess that in the future we will be able to subtype them. But right now we know that it's very difficult to subtype them, and we always prefer to suggest treatment, continuous treatment for all the patients right from the get-go, despite the fact that there might be a subset of patients who will not need continuous treatment.
Well, I mean, taking the case of Emma again, the question is, would you say it is difficult to judge whether there is a relapse coming up? Would you say there are clinical signs of an early deterioration, so a patient being stable like Emma and then possibly having stress at university or within her relationship? Would you say from the clinical grounds that you can judge there is a relapse coming and then can react with adjusting the medication?
Emma is a university student. She's exposed to stress. She picked up her medications on a regular basis from the pharmacy, but still probably was not adherent. The question is, in this case, if we would hypothetically position long-acting injectables for Emma earlier during the course of illness, could we prevent the relapse because that happened because of the combination of non-adherence and stress?
But I mean, that brings up the question, if Emma in a way had a benefit from taking medication, why do you think do patients like Emma discontinue medication?
I think that we don't know. I think that there are many reasons for non-adherence. We can mention the side effects, we can mention the insight, we can mention even the story that a lot of chronic illnesses, patients who are diagnosed with chronic illnesses are not so adherent with their oral medications. We can think about blood pressure, high blood pressure, diabetes type 2, and so on and so forth. So adherence is a problem. But the problem here is that the clinician doesn't know, and the clinician usually overestimate the level of adherence of his own patient with oral antipsychotics. And maybe we as clinicians sometimes underestimate the negative consequences of relapse.
But would you agree that one of the important points, I do agree that there are several sort of reasons coming together why patients do not adhere, But don't you think one of the important points is whether they are actually show a remittance of their symptoms? So if they feel well, if the symptoms go back and they recover, then it's less likely that they will sort of discontinue medication. Would you sort of agree to that?
Yeah, definitely. I think that a lot of patients and sometimes their family, we call it the antibiotic model of schizophrenia. They take medications when the symptoms are still there and stop when the symptoms are not there. So we have, on a psychoeducational level, I guess, explained to the patient and the family that we are talking about a chronic illness and relapse might come despite the patient is doing wonderful and is fully remitted from his symptoms.
So taking again Emma's case, I mean, we have a 21-year-old student having different pressures in life, you know, starting with university and having other issues, looking after herself for the first time in her life on her own, living independently. So she might have been good on the medication, but then she's getting worse, possibly taking it on a less regular base. So what would we think? I mean, as the clinician, as the treating psychiatrist, what could we actually do in order to avoid the next relapse?
What we usually do in our clinic, we position long-acting injectables very early during the course of illness. In one of the studies conducted by Dr. Remington from our clinic in Toronto, we showed that despite the fact that patient will report of full adherence, and despite our clinical judgment that shows that probably the patient is adherent with the medications, we don't really know. We use the MEMSCAP, some kind of an electronic device that the patient didn't know that we put it there. We got some kind of REB approval for that, not to tell the patient, and we show that we actually don't know what's the real level of adherence with oral antipsychotics. That's why we position long-acting injectables very early during the course of illness.
So if we take Emma again, so we would recommend her long-acting antipsychotic, because what might happen? What are the costs of the next relapse? Maybe we could sort of put this down in one or two arguments?
Yes, I think that there are many negative consequences to a relapse, second or third relapse with our patient with schizophrenia. We can talk about psychosocial consequences. Sometimes after the relapse, the patient finds it very difficult to gain all the achievements he had before. We can talk about response that is not the same. Maybe hypothetically we are talking about some kind of neuropathological changes, hypothetically, that happened in the brain, so response is not the same for consequent episodes. We can talk about other things, the huge economic burden, the burden on the family, the emotional burden on the family. So there is a long list of consequences, negative consequences to relapse. And the main question is, can we prevent it before it happened? And I think that position long-acting injectables earlier during the course of illness can prevent relapse.
So I think we agree that the costs for the sort of next relapse in Emma's case is something which is so high that we need to prevent the next relapse. But still, obviously, there are pros and cons of long-acting antipsychotics. So if we sort of coin it, put it down as one or two arguments, what are actually the cons? So we have spoken about the pros, but what are the cons? So why is it so that there is still an ongoing discussion about why long-acting antipsychotics are helpful?
I think it's a very good question, and the main question is what's the utilization rate of long-acting injectables, which is relatively low, at least in North America, although I'm proud to say that in our clinic is higher than the average in North America. I think it's related mainly to the attitude of the physician. I think that there are a lot of myth about side effects and so on and so forth that prevent clinicians to position it early. Some clinicians think that there is a punishment, some kind of punishment, quote unquote, to the patients to position long-acting injectables very early. I think that it's very important to position it early, and we are doing a lot of psychoeducation to explain the negative consequences of relapse, and we are making any effort to prevent the next relapse for our young patients.
The other thing I might add to this discussion, I think that also the literature is, let's say, certainly heterogeneous. But if we look at the mirror image studies, it seemed to be that long-acting antipsychotics have a pro compared to oral medication. And I think that needs to be taken into account with all these sort of various discussions we have here.
I think that the literature might be confusing because LAI at the end of the day is not for everybody. There is a subset of patients that we can prevent relapse better with LAI, but we should remember, as we said before, schizophrenia is not one illness. There is, for example, a subset of patients who are clozapine patients, treatment-resistant patients. For these patients, I wouldn't recommend LAI. There are patients who are religiously adherent with oral medications. There are patients who might need a different dose and different regimen. And that's why I think that the jury is still out in terms of the literature. But as you mentioned, if we look at the mirror image studies or studies that selected the right subset of patients, we can show in these studies that LAIs are better compared to oral in relapse prevention.
So I think that was a very fruitful and intense discussion. I think trying to wrap it up based on our case, Emma, I think we have a young woman, changing her life, going to university, having new stresses. In addition to that, having the diagnosis of schizophrenia, so being sort of vulnerable to stress. So we have to make sure that she's well protected against the next relapse. I think we put this together, Ofer, quite nicely. So it would be the case really to go her and discuss with her whether it would be a good idea to put her on a long-acting antipsychotic. I mean, we have a variety of drugs today on the market, so we should use the substance which is best suiting her and helping her in order to prevent the next relapse. So that would be one of our main goals. And I think overall, we have discussed the pros and cons. So with saying that, I'd like to thank you, Ofer, for joining me with the discussion. And I thank you for participating in this activity. Please continue on to answer the questions that follow and complete the evaluation.